start this morning, I'm going to have each of the panelists just give you a brief overview of what their role is, what they're doing, and what is their passion or how they are impacting women's health care. So Sabrina, I'll start with you.
And we're focused solely on drug development in women's health. So pharmaceutical drug development very broadly. We have 13 different products in development. And I started the company because I was very disappointed about the lack of industry commitment to women's health to bring new treatments to market, and decided instead of whining about it, do something about it. So started the company 9 years ago, and really proud of the work we do and looking forward to the discussion today.
And I'm passionate about women's health for lots of reasons. I think one big one is I was a little bit embarrassed to realize that I always thought of women's health as bikini medicine, and it's really just health. And it's every product I've ever worked on has a component where women are not served as well as men are. And I've always been a lover of the underdog, so I really love the fact that we are having this focus now for women's health and really want to change how we approach it.
I'm our national practice leader for our actuaries, and what that means is I get to investigate, interrogate, and use numbers to tell a narrative. We'll talk about the narrative here around the disparities in women's care, which is really important to highlight. The other thing to note, and the reason why I'm so passionate here, is I'm a girl dad. My job, my career will not be judged on all the stuff that I can do. It'll be making sure that at the end of the day, healthcare is better for my two daughters than it is for my wife, than it is for my parents.
Deloitte just published a recent report on the gaps from a gender perspective in women's health care. So we're going to kick it off with you to share some facts that I think will be surprising, but also not surprising to some of the folks in this audience.
We published a report around the gender gap, and I want to take you back to where it started. So I was reading an article about the cost that women have when they bear a child, which is, by the way, significant. It's $3,000 when you go to deliver a child. And the thought that crossed my mind was, well, how often do you have a single expecting father? It's rare. 40% of births in the US are single women. And are we putting a cost, are we taking money from women that we're not actually taking from men? And so we dug into this and we explored. I got Dr. Gabrias, who is a co-author on this, together, and we said, let's figure out if maternity, go back to your comment about bikini medicine, if maternity and pregnancy-related costs are driving a disparity in care. We looked at 16 million members, men and women, employed 19 to 64. And I love to say it and I hate to say it, we were wrong. What we found is $15.4 billion is what women spend more out of pocket than men, without including maternity or pregnancy-related care. It wasn't the driver. Now, if you add that in, by the way, it gets worse. It gets 10% worse. It gets to about $17.1 billion. But it is all the care that is required to prevent, diagnose, and treat women, because women are different than men. And we're spending a lot more. And you could say, okay, that's $15.4 billion. Put that in context. These are employed women. What we found is if you look at the wage gap and you say, okay, well, women are making less than men. I'm going to take away benefits and I'm going to take away taxes, and here's now what's left in your wallet to go make a choice about health care. We're making that choice harder for women every single day. And that is essentially why it matters so much. The other things that I'll say about the analysis is two things, because people often ask, well, why is this happening? Are they going to the hospital more? No. 51% of women have a cumulative spend over a 12-month period between $1,000 and $10,000. That range is really important. As an actuary, I love this range. It's the range where you are paying your deductible, right? So you're paying that. You leave your deductible level, and then all of a sudden you have co-pays and co-insurance. The problem with that range is you actually never have a free claim. You never reach the point where you have free services. And so at that point, every time you go to get care, you're making a choice about the dollars that you spend. Only 42% of men sit in that range. And so it's not that you're going to the hospital more, it's the fact that you spend time, and it's a little bit more harder with labs and pharmacy and everything else to care for your bodies. One last thing is the argument is that, women care more and men are stubborn. I live in my house. I think that's true. But in healthcare, I can tell you with numbers that biologically and physiologically, the cost that women are spending in healthcare is because your bodies are different. It requires different care, and women aren't men with ovaries. It's different, and we need to think about women's healthcare differently.
But there are also tremendous outcome disparities and other equity disparities as well that I'd like to have the panel talk about. Obviously, at GoodRx, we're focused on affordability and access for all. But, our kind of super user, the household health manager, the chief healthcare purchasing officer tends to be about a 55-year-old woman, let's call it 45 to 55, who is taking care of children, who's taking care of parents, who's taking care of herself. And regardless of insurance status, for example, 1 in 4 Americans use GoodRx and come to GoodRx and depend on us. 75% of those people have insurance. We're talking about people who are working, like you said, they have coverage and other things, but still are having a problem affording their health care. We're proud to play a little part in that, but I want to talk about the chief healthcare purchasing officer a little bit with the panel, and now talk a little bit clinically, like why are there such disparities? Why is there a change in outcome? We understand the economic impact, but
historically there hasn't been as much research in women. It wasn't until the 90s that women were required to be included in clinical research, and really everything we're experiencing now, quite frankly, is a little bit of a ripple effect from that. So there's biology we're still trying to figure out and understand. There's complexities in terms of differences in how women therefore manifest, with disease, and then so you compound that also with that has a ripple effect, because then you don't do as much drug development because you don't understand the biology maybe as well, or you don't understand your targets as well. That means from a regulatory perspective, the FDA may not be accustomed to seeing as much. And then you get all the way down to then marketing and commercialization and promotion. The providers aren't used to new treatments being out there. The consumer's not used to asking and advocating for herself. So I think it's all of that together has gotten us where we are today. It's solvable, which is good news, but I think it's really that ripple effect that, in my view at least, as a drug developer, in large part started with the fact that we didn't include women in research as a requirement until relatively not that long ago.
I learned last night exactly, 1993. Yeah. Prior to 1993, women were not included in clinical trials.
Maybe one of the reasons why women spend so much more in healthcare, we know from data that women engage in healthcare more, especially in prevention, 2/3 of the time more often than men do. So I think we have a different issue with men where they don't even engage. But when you do engage, you get better care. So I think I completely agree. I mean, when you start breaking down, it really starts with women not being in clinical trials. There's policy, there's education in medical schools. We can go on, and then it feels huge and unsolvable. But I always want to take a step back and say, what can I do in my backyard? And as a marketer, I'm embarrassed to say it's only been recently that I've actually tried to even look at our data by gender. How many of you actually, if you don't work in bikini medicine, just segment your data by gender to understand at a fundamental level how men and women are approaching their care differently for the disease area? Do we create doctor discussion guides differently for men and women because we know they need to approach it differently? And we don't. We do tons of market research, and we still paint our customer with this one homogeneous brush of the patient with. It's not the woman with or the man with that disease area. So I think that's something we can do better to change this dynamic a little bit.
Well, and I love the way you frame that, because one of the things, we did another piece of work around the inequities within healthcare, and it looked at racial and ethnic, it looked at gender and sex and socioeconomic, and within the gender bias, you have cardiovascular disease, which, by the way, the science has proven that we know the signs and symptoms for women manifest differently. It's not left arm pain, it's jaw pain, it's back pain. Cardiologists are trained on this when they go into the office. Yet still at the moment of care, the education that's required, how do you actually have a script to know that a woman's coming in with back pain? That's a sign that they're at risk or having a heart attack. We need to diagnose it that way. And even with the training, they're still making and having an unconscious bias around, oh, that's stress or anxiety or cramps or something that is driving the decisions and not actually driven on outcomes. It's driven on perception and the bias that shows up at the moment of care.
What do you think that marketers, manufacturers, et cetera, can do today, or what have you done today to think about how to improve affordability and access as you move forward with your compounds in development and your compounds?
I would say for marketers today, it's not enough to just really think about physicians and your consumers or patients. You really need to think about the third rail in this discussion, which is payers and employers who reimburse. And I really feel that we have not done a great job of building the story for that segment of the healthcare industry. We certainly do pricing, we do contract strategy, we talk about having a payer value proposition, but what does that really mean? Because if you think about it, the people that are furthest away from the unmet need and the impact of the disease to the patient is the payer. And payers are not soulless. They are human beings. They're dealing with probably similar challenges. How often do we paint a patient picture for them? And I'll give you a very tangible example. You know, working on one of our products, we realized that some of the prior authorizations are really delaying care for women. In fact, it can take over a month from the time the woman gets the prescription in hand for the PA to be approved and for her to maybe go pick it up. And there was significant abandonment happening because a woman's not going to wait for a month if she's in pain or has acute conditions right now. And so when we shared that data with the payer to show the payer the impact of their policies, it was an eye-opener for the payer. So I think it's incumbent upon us to make sure that as we launch new products, as we bring new indications to market, that we build that story. And it has to be the economic impact also to payers, the delay in care, the fact that they're taking other rescue medicines, going to the ER more often. We talk about healthcare-related utilization costs, but we don't always build that into the narrative. So I would really urge all marketers to really think about all three of those pillars as you launch new technologies.
You know, we used to feel like I was sharing this when we were all prepping, that the FDA approval was the finish line, right? When you're developing drugs, you're like, yay, we did it. It's approved. And that's not the finish line. It's the start line. You know, we talk about bringing the voice of the consumer in. Absolutely, when we're doing our research and making sure that this company working in women's health, right, we're focused on her. But we also have to bring in the view of the payer. I mean, that is the reality. If she doesn't have access to the treatment, there's no point moving it forward, right? The only things that are going to work for her are the ones that she can actually get prescribed. And so in the end, it comes down to that. How are you going to have those payer conversations, right? Is your label for a therapeutic, right? Is it going to be differentiated? How do you ensure that it's differentiated? How do you ensure that you've got the economic story, right, the pharmacoeconomic story around that differentiation, and planning that like into your, not only into your clinical research, but quite frankly these days, like choosing also your indication that you're going to pursue. Taking the time to have those hard discussions with the FDA and making sure as marketers that somehow within your organizations you have a voice, right, and a seat at that table when those decisions are being made, because in the end, you know, the payers are now the gatekeepers, and we use a phrase internally. I feel like women often get the worst first because that's the cheapest, and it may not represent innovation that's available today. So we got to change that paradigm, and part of that is thinking up front. Yeah, the other thing we look at clinically are two things. One is, you know, making sure we're capturing what really matters to the patient in our clinical research, and sometimes that means having to have hard conversations with the Food and Drug Administration because maybe that's not the way they were thinking about the indication or thinking about what clinical data is important. And so, you know, for instance, we're developing something for women for arousal disorder. We've spent 3 years like working with the FDA on what is arousal disorder in women. It's sort of the same as erectile dysfunction in men, but not. Right? What are the right questions? What should we be looking for? And to get the right product to market, doing that work up front. And then the other piece is making sure, for all the reasons that we were talking about and around, you know, women are sort of supporting up and supporting down and taking care of everyone, and they kind of come last. how can we make sure it's easy to participate in clinical research as a drug developer, and to make sure you're getting the demographic that you want? And that takes intentionality. That is not simple. It takes a lot of thought and effort. And I won't belabor it here because I know we're limited on time, but I was sharing at breakfast, like there were things that we learned running clinical trials during COVID, which forced us to kind of rethink and remodel how we do research that we do now, because we realized it made it so much easier for women to participate with like not requiring so many visits and using telehealth.
I was happy at this year's Super Bowl when I saw ads for hot flashes and menopause, and knew how many millions of households were all sitting there with popcorn and chips and everything else, and there are people talking about hot flashes and menopause. Can you all talk about, maybe from a positive perspective, how you think that things are changing from what I'll call taboo subjects to kind of trending, and what's influencing that, and also how are you participating in that?
I feel like in some ways menopause is having its moment, right? We're talking about it, which is fantastic, but we have to do more, and it is improving. And Forbes last year did a piece around the fact that sites like Meta were banning certain words because they viewed it as adult content around like vagina, right, or sexual health, right, or sexual pain, and they've changed, right, some of their practices, but it's really taken people speaking out. So I'm definitely a firm believer that part of removing the stigma is having the conversations and using the appropriate language. I did a piece on LinkedIn a couple years ago because I did an interview for a podcast, and they ended up not being able to air it because they said I said vagina too many times, and our products are mostly vaginally drug delivered, so I was running out of like euphemisms for it, and nor did I want to have to. So so I think part of removing the stigma is having the conversation, speaking out. That's on all of us, and using the right language.
Couldn't agree more. And working for Pfizer, 20 years ago we talked about erections, and hard erections, hard enough to penetrate. Those were words we had no problem saying out loud. I think we can say dry vagina or a moist vagina and not cringe. So I think it's really just saying it and saying it and saying it in simple ways. I also feel we are in this moment, and some of it has been accelerated by the pandemic, where we know women were disproportionately impacted, especially women were more the frontline, essential workers. We know women make up 65 to 70% of the healthcare industry, the Me Too movement, the assault and reproductive rights. I think it's really giving women a platform and a voice. I think we're angry enough to say, you know what, I'm going to say what I feel, and I'm going to say it the way I want to say it. And I also feel in the US especially, women in their 40s and 50s that we were talking about, the chief purchasing officers, we have more economic power than we've ever had as a generation. And we're using it, and we need to use it better. So again, as a market, the example I'll share is, we really want to fix the broken dialogue between doctors and patients. And oftentimes, we feel this need to really couch all the physician resources in very clinical language. And an example is the word dyspareunia, which means, I don't know how many people know what that means, but it means painful sex. No doctor is asking a patient, are you suffering from dyspareunia? And certainly no patient's walking in and saying, I have dyspareunia. And what is taboo and hard to talk about is painful sex. So we are trying to bridge that, and we are making sure that that language is simple and clear and getting to the heart of the issue, and really trying to make it no longer taboo, but something that everybody can talk about. And frankly, talk about at the barbecue and the dinner table, because guess what? 52% of this population of this country are women, so we should be talking about it.
And the only thing I would add is I wouldn't have been here talking about this 6 to 8 years ago. So the conversations that we're having now have enabled me to do that. I'm having this with my family, with my colleagues, with my friends, because I think it is something that now you can talk about. And I would not have felt comfortable as a white dude sitting up here talking about women's health 6 years ago. And that's just, for me, that's empowering, because now I feel like I can make strides talking about things that are really uncomfortable with my kids, with my wife, which I probably wouldn't have had 10 years ago.
I do believe each of us can help address the stigma, whether it's in your community, whether it's in your employment, or whether it's in your church or other things, and even within your family can make a difference there. One thing you are seeing too, we didn't talk about them at employers. Employers are increasingly adding benefits to their employee, and this also happened in the last 5-10 years too, to retain employees, to attract employees, and also because of employees kind of rising up and saying something. So fertility, family forming, you have companies like Progeny, Kindbody, Carrot that are being added as benefits. Even mental health care, again, mental health helps men and women, et cetera, but it is disproportionately, just even adding mental health benefits to an employee population is tremendously beneficial to women. And you mentioned as well the rise of what I'll call virtual care or telehealth. For many, many women, going to the provider, whether it's for themselves, their parents, their children, is also a challenge. What's your number one takeaway or ask from this audience that you'd like to share in our speed round? Sabrina.
Oh gosh. Well, so I think we all agree that women's health is healthcare, but the takeaway is I think we all have an opportunity and responsibility to transform the health and well-being of women. And it starts at the individual level, right? Ask, not just ask, but demand the care that you deserve. Use the right language, right? Talk about your symptoms and really like seek answers and speak out.
My advice to marketers would be trust the data but verify, and really just look at your data from a gender lens to see what you're missing, and listen to women in market research. I think that, that may feel old school because it's all about data these days, but listening still goes a long way.
It's the employers, right? We have the right to ask for these changes. What I started with the data was all benefits. By the way, employers own those benefits. Your work for your employers, your workforce actually own the rights to change those benefits and actually do better for the women and their workforce. And you can ask for that right now. It goes back to your question, Sabrina. Ask and demand what is going to be better care for everyone and hopefully leveling the care for women.
I want to thank our panelists and our audience as well for your attention today. Really appreciate it, and I hope that we all can do one thing today to make a change. Thank you.